Good afternoon, everybody. Good morning, good evening. I know we have people tuning in from all over the world. So hello from New York City. My name is Joanna Teeters. I am the support programs manager here at CurePSP, and I'm thrilled to be joined today by Heather Cianci and Lauren Zaloof from UPenn. They have so graciously carved out some time to do a quick Q&A with us. I want to quickly give a brief bio for anyone who is just joining us now. Heather Cianci is the outpatient neurological team leader and founding therapist of the Dan Aaron Parkinson's Rehabilitation Center, Penn Therapy and Fitness at Pennsylvania Hospital, which is part of UPenn. Heather has published research in bed mobility, falls, and freezing of gait in Parkinson's disease, and teaches about rehabilitation in PD at Thomas Jefferson and Newman University's departments of physical therapy. She is a former member of CurePSP's board of directors and founding member of the comprehensive outpatient atypical Parkinson clinic at the UPenn Parkinson's Disease and Movement Disorders Clinic. So thank you so much, Heather, for being here with us this afternoon. We're going to jump into some questions in a moment. She is joined here today as well by Lauren Zaloof, who is a graduate of the UPenn School of Social Policy and Practice, where she received her Master of Social Work in 2018. During her master's program, Lauren completed the Penn Aging Certificate Program and gained specialized skills and knowledge in the field of geriatric work. She completed her advanced year field placement with the Penn Memory Center and continued on as the interim social worker following graduation. She is also an active member of the Pennsylvania Society for Clinical Social Workers and has a passion for serving patients and families living with neurodegenerative disorders. Again, thank you so much for being here, Heather and Lauren.
Our pleasure. Thank you for having us. Yeah, thank you.
Absolutely. So I know, everyone here knows that this is a virtual family conference. We were together in person in November in Pennsylvania. So we appreciate you taking the time to answer some questions here. Today's Q&A, we're going to jump into with some questions. First for Heather. We're wondering, what can people expect for their first physical therapy appointment?
That's a great question. So I'm going to answer that from the eyes of an outpatient physical therapist. So when we first meet with someone, typically someone is given a prescription that from their physician, their neurologist, their primary care physician, it could be a nurse practitioner, saying, we want you to meet with a physical therapist. We're noticing some changes in your mobility, maybe some issues with falls. Maybe we need to get you on a better home exercise program. So when someone comes into our clinic, unfortunately, there is some extensive paperwork that you usually have to fill out because we want to know a lot about you. We want to know not only things about your past medical history, perhaps if you have high blood pressure, things of that nature, but we also want to know what kind of issues functionally are you having. So we'll ask you about your day. Where do you live? Do you take the bus? Do you drive a car? Are you still making your own breakfast? Are you working? Do you volunteer? And then we ask questions about, what are you having challenges with? Do you need a little bit more of help with perhaps getting up from a chair? Are you having issues with your walking? Are there falls? And really kind of getting to know the person. I think that's something that's so important, that we don't want to just see someone as their diagnosis. We want to see them as the whole person living with that diagnosis. So if we get a good idea of kind of who they are and the challenges they're having, that leads us to being able to have a better idea of what test we're going to do. So that first visit is really about getting a baseline of that person's function. So we do anything from testing people with how fast they're walking, how well they're able to get out of a chair. We'll do a bunch of balance tests. If you are somebody who still needs to climb up and down stairs, we'll take you up and down the stairs. If you're somebody who falls frequently and you have to get up off the floor, we'll test you with that as well. And then we look at range of motion, strength, your coordination, those things. And that gives us a good idea of, what are the challenges someone's having? What are the difficulties that we're seeing? Is it weakness? Is it lack of coordination? Is it perception of balance? And then we're able to set forth our goals of what we're going to work on together with them in the clinic, as well as what we want that person to work on at home with their loved ones, their family, their friends, because it's important to learn those things in physical therapy, but if you don't carry them over into the home, that's where most of the change occurs. So we really want to help people feel comfortable with taking the information we impart to them and then applying it into everyday life.
That's wonderful. And it really leads, Lauren, I'd love to hear from you and from you, Heather, as well. What is I know you two work together at your clinic. Even just right before this call, you were finishing up some documentation for your joint patients. Could you speak a little bit about the differences and similarities between physical therapy and occupational therapy?
Absolutely. So I think a lot of people have a good or a better understanding of what physical therapy is, but sometimes they're not even correct in what they're thinking. They think maybe we just help people who have had a knee replacement or a hip replacement or back pain. I think those of us that work with older adults or people who have neurological problems, we really, like I said before, get into the nitty-gritty of function. It's more about how do you do these activities and how do we provide you ways to continue to have a good quality of life. So what I talked about before with the balance, with the range of motion, the strength testing, those are all basic things that we look at, but it's how do you perform the movements that you need to do to be able to live your life. Whereas our occupational therapist, people will often think, well, I don't need an occupation. I'm already retired. I don't need another job. You're not going to help me to do that. And what she says is, no, it's the occupation of life. How do I help you to be able to balance your checkbook? How do I help you to be able to figure out how to pay a bill a certain way online? How to use your phone? So a lot of more of the nuanced things where you're really what we call activities of daily living, cooking and cleaning and dressing, but also from a cognitive standpoint, occupational therapists are specialized in helping people deal with stress, with problems with sleep, and lots of things with just being able to keep the skill set of things that they want to do, reading a book. And if they can't read a book, then is there something we can do to help visually with that? Or do we change it completely to a book on tape? So I think there's a lot of crossover between what PT and OT do, but there are subspecialties that we have. And if you're lucky enough to have a great team like we have and you get everybody together, then you get the full deal for that. So it really complements one another.
And then I might meet with the family first or speak with the patient and the care partner first, and they might identify having trouble with, maybe paying the bills, or it could be, really loving to read and not being able to, because of their vision impairment, they can't necessarily read a book anymore, but they still want that to be a part of their life. And that might mean then I identify a need for occupational therapy, right? How do we bring these activities that they used to enjoy back into their life, but just for it to look a little different? Maybe it's audiobooks, for example, but that might mean once I hear that that's something that they're struggling with, or they could use a referral to PT and OT, that's kind of when I collaborate and reach out to my team.
And then we go back to her and say, how do we find funding for this? How do we find some help in the home? What can they apply for as a grant? What does their insurance help? So it's never just one way. It really continually goes back and forth. Yeah.
Absolutely. And thank you so much for such a thorough answer. And my apologies if I misspoke at the beginning of the question and referred to you, Lauren, as the occupational therapist. We know you're a social worker. A question for you, Lauren. Do you recommend in your experience, having care partners and patients having separate appointments with you? Or is it helpful for you to see families come to you as an entire unit, or do you prefer to see people individually?
That's a good question. I think, and I know you're asking me, but typically, like when they're meeting with their provider, it's always helpful for people to come together to be on the same page so that they both hear the information that the provider or the movement disorder specialist or the physician is sharing. Sometimes people want to have a chance to just speak individually without worrying about, the other person hearing the same news, or being able to just have an outlet to share and not worry how their words are going to impact someone else. So sometimes people do just want to meet with me individually, and I'm totally open to that. I think it really just depends on the needs and the goal, because sometimes it could be coming together to talk about resources for the future. And that impacts the patient. And so I think having both people together in that kind of case, it's sometimes helpful because I want to hear from the person who's going to be receiving those services. But sometimes if the care partner just really needs an outlet to share, if they're struggling, for example, it might be helpful just to have a chance to speak to me. So I know the answer, it depends, is frustrating, but usually it does depend. And what also they're comfortable with. Some people don't feel comfortable talking behind someone's back, that kind of thing.
And I imagine that might change as well. I'm sure you develop relationships with families and patients, throughout their time at the center that you're working at. And so I'm sure that can change. If a person feels like they might, really benefit from some one-on-one time, that can be honored. So that's wonderful. Thank you so much for that. Sticking with you, Lauren, I'm wondering if you can talk a little bit about how someone might best prepare for their first social work appointment.
That's another great question. So I think, a big part of social work is meeting people where they are, which I think I said that in my presentation. And, they might come in and, really want to focus on, we need help at home right now. That's our main goal. And sometimes usually the questions I start to ask are what you might qualify for. So are you a veteran? Do you have long-term care insurance? What do your finances look like? And you might know that all on the top of your head. But those are usually the questions I'm going to ask, because I want to make sure if you qualify for anything through your state or your county, to see if rather than having to pay out of pocket right away for services, I want to make sure that you're using benefits that you're eligible for. So those are usually questions I ask. But it's always hard to prepare because you might come into the visit. Maybe you're seeing your doctor and then you're meeting with me afterwards, or your social worker afterwards. And sometimes you're feeling a certain way in the visit. You can't necessarily prepare for that. And really, social work is offering a space for you to share and get support wherever you need in that moment. So whatever that is for you in that day. So sometimes what I'm saying is it's hard to prepare for. But I think just thinking about what you want to get out of the visit, whether it's getting resources, planning for the future. And that's honestly part of my job, is helping to identify what the needs are.
So sometimes our patients won't know. They'll say,
That's true.
I'm meeting with Lauren for social work. What's she going to do?
Right.
And so there is some explaining and education. Sometimes it's saying, using her quote, she's going to meet you where you are. You're going to feel free to share with her how you feel right now and what you might be afraid to ask for. It's okay. It's okay to ask those questions. Exactly.
Wonderful. Thank you so much for that, Lauren, and for chiming in there as well, Heather, and giving us a glimpse into how those conversations might come up. Switching gears a little bit to some more, kind of tangible stuff here. I'm wondering if you can spend a little time, Heather, talking about whether or not virtual home physical therapy sessions are still something that you're engaged in. If people are not receiving those sessions or treatments right now, are they available for our community? What's the experience with that right now?
So prior to 2020, we never gave a second thought to anything virtual in the world of physical therapy and maybe in medicine in general. It's something that's very counterintuitive to us as physical therapists, because we do a lot of touching and holding of people and challenging them that way. So I can tell you that it was a little off-putting and a little scary, I think, for us as clinicians as well. But it was the only way that we could still treat and work with people. And we actually ran our atypical clinic virtually for many, many months, maybe even up to a year, until people were able to come back into the clinic. And yes, it is a possibility. Is it my favorite way to do it? No, I would always rather be one-on-one, but it gives us the ability to reach out to people who are rural, It gives us the ability to reach out to people who may not have transportation to be able to get here. And the thing that it gives us a real positive of is I can see the person's house now, right? They can tell me how their bed looks. They can tell me what their bathroom looks like. But now if they can take that laptop and that tablet and move it into the other room, I'm able to actually see that situation and problem solve with them really on the spot right there. It's a little harder to fully challenge people with balance and walking and safety. Oftentimes when we do this, we do ask another person to be there so they can move the camera around for us if we're asking that person to move. So it's always better than nothing. You know, if you have the option for it, I would say go for it. What do we know about where Medicare is going with that? There is the thought that it will be ending in the coming year unless there is passage of an extension for this. It is different state to state. It is different country to country. So you really do need to check with your therapist to see what is covered. It is also different insurance to insurance. Some insurances are still covering it. Many have stopped from that. So you always need to ask those questions beforehand. But there are absolutely positive aspects of using it. And I've probably reached many people that I wouldn't have been able to in the past this way. Yeah.
And kind of piggybacking off of your comments about, you know, seeing somebody's home, you know, in my work with our community, I'm always encouraging folks to bring in somebody to provide a home assessment. Could you speak a little bit to that? And, or actually both of you, really, this is a question from both of you. Does that land within sort of the purview of a physical therapist, or would that be something that we'd want to bring in an occupational therapist or a social worker for? What's usually the process for going about attaining that?
There are many different avenues that you can take. When it comes to Medicare, for outpatient therapy, so that would be covered under Part B, we as outpatient therapists can go into people's homes and see them in their homes. And that doesn't mean it always has to be in the home. So I could be seeing someone who comes into the clinic twice a week. And one of those visits, I might say, you know what, I think I need to come out to the house and check it out. It can be done through a physical or occupational therapist. Again, what you need to do is find out their comfort level and their training with that. And it is covered by the insurance, at least for Medicare. Many of the other insurance companies tend to follow what Medicare does, so that's great. I always think two heads are better than one, so you can get the PT and the OT out there, that's great. In different situations, though, we are not home rebuilders or home remodelers. We need to contract with people who do that. There is an organization called CAPS, Certified Aging in Place Specialists. A lot of those people tend to be therapists anyway, but some of them are home contractors, home remodelers, builders, and things like that. And they know the actual width of what a handicap door regulation size should be, or are these stairs too steep to actually have a ramp? So you do need people who have that structural understanding that's there. And Lauren might be able to talk a little bit more about sort of, you know, where that coverage can come from in organizations like PCA here in Philadelphia.
Yeah. So basically, if you wanted to even find a social worker near you or learn more about resources in your area, I would suggest, especially if you're living in the States, I know we have people from all over, but each county in the country has an area agency on aging, which also services people who have disabilities. So if you're under 60, you could still utilize that as a resource. So, you know, depending on what county you are, you can type it in Google and look up your county. There's also locators. If you just type in your state and find area agency on aging locator, and they can help you get right there. But they will have a list of like different home modification agencies or, funding sources for ramps, for example. I mean, all of that you could find through your office on aging. So that would be like a good place to start.
Wonderful. Thank you both. Sticking with you, Lauren, how often do you recommend that a patient or a care partner should be seeing a social worker to kind of reevaluate their needs at that particular time or planning for the future?
So I really think it's up to the person and the care partner, when they feel like there's a need. So especially with planning for the future, I always recommend people do that earlier rather than waiting for a crisis or an emergency or a big change to then reach out for support and planning for the future. So I think, oftentimes I meet with people after their visits. So let's say they're coming in every 6 months and I'm happy to meet with them after their visit, for example, or it could just be someone calling in between with a question or, noticing that the person at home needs more help or noticing that they're starting to feel burnt out and they themselves need some more support. So I think, again, it just depends on the time, and it doesn't necessarily have to be like every 6 months, but I guess the idea is that I'm here as a support, and if people notice that they're starting to need more help, they can reach out anytime, kind of a deal. But if they wanted to meet with me after their visit, so I guess it depends. I'm sorry, but
Could you speak a little bit to the difference between a talk therapist, psychologist, and the work that you do as a social worker? I know we talked a little bit about resources, but I'm wondering if you can expand a little bit more on really the difference is, we know they're both very supportive folks in this care journey, but speaking a little bit more to the differences there.
Sure. Both a psychologist and a social worker, they could both be therapists. I'm a licensed clinical social worker and I provide counseling, I provide therapy. So I think it depends on what context you work in. So for example, there might be some social workers that don't have the capacity to provide ongoing psychotherapy. So ongoing meeting once every week with a patient or a client every week. So they don't have the ability and they're just providing more brief treatment, brief counseling. So just, when speaking with someone, they might provide more emotional support, empathetic listening, that kind of thing, but they don't have the ability to talk, go back into your trauma in your childhood and kind of delve into that because that's not their role. So just to clarify, a psychologist and a social worker, they can both provide therapy. They have different lenses and different frameworks that they view things from. Again, in my setting as a social worker, I can connect people to resources. That's another big part of what I do, but I can also provide therapy and counseling. So it just
depends. You wear many hats.
I wear many hats, and some people in some settings as social workers don't provide therapy. So it just, depends on the setting that they're in.
Certainly. Thank you for explaining that a little bit further for us. Heather, we touched on this already a little bit when you were discussing, what a virtual physical therapy appointment might be like for someone at home, and mentioned a care partner maybe helping to turn the camera or provide an extra set of hands if you're practicing, certain walking things or balancing things.
Yeah.
Are there other ways that you can speak to that a care partner might be able to be involved with physical therapy and really encouraging the person who's receiving that therapy to continue on?
So it can be a really critical role, and it can be a very challenging role. So I'm going to take from the lens of a care partner who wants to be there, who wants to help, who has the capacity to help, physically and emotionally. Many people are experiencing problems with memory, with impulsivity, problems with unsafe kind of judgments. And that's where the care partner needs to come in to remind them, remember, we put our hand on the rail. Remember, you need to use your rollator when you're walking. Remember that if you get up, you need to call me for help, these kinds of things. Mm-hmm. But we also work with the care partners in teaching them how to physically help someone if they actually need, moderate level of assistance to swing their legs into bed, or they need to be able to steady someone while they're walking while holding onto their walker or gait belt. So from a physical standpoint, that can be very helpful. I think the emotional support sometimes is even more important. It's very difficult for someone to be a husband and a wife, or two partners, long-term partners, or a daughter and a mother, and now become the one person is the care partner and the other person is the quote unquote patient. You may not have any training in that, right? You could be a CPA and know nothing about medicine, and suddenly you're thrust into this role. And that's where, again, you need like a whole team to kind of work with you and teach you how to help that person and give them what they need. So it's going to depend again on that person's willingness, their level of comfort with them. Sometimes people don't want to do that. Some people want to bring in outside help, and that's okay. You still want to be that couple, and that's not your role. So again, meeting that person where they're at to show them how to do it. And a lot of times care partners and loved ones mean well, and they'll sort of do things incorrectly by, maybe standing in front of the person and lifting them with both hands. And then the care partner falls back as the person stands up. So in those cases, that's where it's like, okay, come on into therapy. Show me how you're doing this. We want to teach you the safest way of doing it. So it's that whole kind of teamwork framework, again, that goes into that. And if you do have someone who has a home health aide who's new to working with someone, we train the home health aides as well. You can teach people different ways of doing stuff so that you're all doing it the same way, because the home health aide does it one way and the partner does it a different way and the son does it a different way. It can be very confusing and overwhelming for that person living with the disorder. So there's a lot of education that goes into that as well. So, 9 times out of 10, we want that person to be there. Sometimes we decide, okay, that's not the right role for them. We're going to get some outside help.
That's a wonderful answer. And I'd also love to highlight just what you just mentioned about really connecting those folks who are on your care team. Having a home health aide, you can connect them with the people who are providing social work or physical therapy care, so that everyone can start to speak the same language a little bit more and ultimately move towards a safer and more improved quality of life. That's wonderful. Thank you. We have a few more questions and a few more minutes. And I also want to remind everyone out there who's listening. Well, first of all, thank you all for tuning in. If you do have questions related to physical therapy or social work, now is a great time to drop them into the Q&A. We won't be able to get to every question, but please feel free if there's something on your mind or this conversation is starting to, bring up something for you, please feel free to ask it now. And of course, CurePSP and our partners at UPenn and across the Centers of Care Network in US and Canada, we're always here to help answer whatever questions you might have about this particular journey. That all being said, Lauren, I'm wondering, this is a little bit of a difficult question because I know it's complex, but do you have any tips for handling the disease mentally without having a dedicated caregiver or a very small support network?
Well, I think, the beauty of CurePSP is that there are so many support groups. And I know you just created a group for people who are living without a dedicated care partner or living alone.
The Flying Solo group is now meeting monthly. Absolutely. Thank you for.
Because I think what can really help, especially what I've seen with my patients and care partners, just in general, is that you never want to go through this disease alone, and having a community to support you through it, I think, can make a huge difference. I think it's often hard, especially for someone who has lived alone or has done things on their own for so long, to reach out for help and accept help. But I think, starting small, if you do feel comfortable joining a group, you haven't done that before, you might be able to relate to people who are also going through the same experience as you and doing it on their own. But kind of reaching out to the people that you do have, whether it's, thinking about different avenues. Maybe you are a part of a religious organization, or your neighbors or other people in your community, but kind of reaching out to the people that are there. And even professionals, whether it's through your center of care or like the social worker, just thinking about the people that you do have on your team, and and not kind of going through the whole experience alone, because there are people to reach out to, even if it's not necessarily someone like a care partner that you have. So Definitely. Building your care team, I guess, is the idea.
Always, and reevaluating that care team.
Totally, and it can
on what
change over time.
Might be. Definitely. Yeah, absolutely. And I have to give a shameless plug to the CurePSP respite grant program, for which I'm the grant administrator for. For anybody that is new to this grant program, please find information about it on our curepsp.org website. It is a grant that provides 60 hours of in-home care for folks who are living with a diagnosis at home. So, there's always resources, whether it's through CurePSP, through your local medical centers where you're receiving care. There's always grant opportunities or local resources in addition to the family, friends, and neighbors that you're surrounded by to help move through this as safely and with increased quality of life as possible. Thank you, Lauren. Let's see, do we have any other questions here that we didn't get to? This is something that comes up in our support groups quite often, Heather, so I'm wondering if you wouldn't mind speaking to it. What are your thoughts on incorporating an Apple Watch or a Fitbit in everyday life as a physical therapist? Is this something that comes up for you in clinic?
Love it. I would like to strap one on everybody. Yes. The epidemic of smoking of years of past is now the epidemic of sitting now. This is the problem, right? And we have become a very sedentary culture, a lot of things, online. We have at our fingertips, and it's very easy to get lost just on your computer, lost on your television. It can be scary to be out there, right? With COVID and different things that are going on, it can be scary to go out when you have a disability or you're somebody who has balance problems and maybe you self-limit and you stay in too much. So yes, we need ways to motivate people and to show people how important it is and how it can really improve, again, quality of life and movement and speech and swallowing and ability to use the restroom. There's just so many things, we say motion is lotion. You've got to stay active to stay active. So yes, if the Fitbit shames you or motivates you into doing something, the Apple Watch does the same thing and kind of buzzes on your wrist to remind you to get up, then absolutely we are all for it, because none of us really go out and say, okay, I'm really excited about doing this workout today. And if you don't have someone to work out with, or your gym isn't open, or you don't even know what you're supposed to do, just the simple act of having something remind you just to stand up more frequently and walk around your own home can be absolutely positive. Yeah, we love them.
That's wonderful. Thank you. I have one more question, and then we're going to wrap it up here today. And this is a question for both of you, really. Which department should a family call to schedule a new patient? And I know you can speak from your experience at UPenn, but I assume that this is an applicable answer to many different medical centers. Which department should a family call to schedule a new patient multidisciplinary assessment?
If it's for an atypical Parkinsonism, you're looking first for neurology and then subspecialty of movement disorders. That's where you want to go straight to that. Yeah.
Absolutely. Wonderful. Well, unless we have any closing comments, I just want to say a big thank you to both of you for being here with us this afternoon. And of course, for all of the work that you did for the in-person family conference. Can't thank you enough for your hard work and sharing your expertise with us here this afternoon.
Well, thank you for having us. It's our pleasure. I think you can tell we're a little passionate about what we do. So we hope that no matter where you're receiving your care, you feel that same passion and warmth from your team. And if you don't, call out to CurePSP and see if they can help guide you.
Definitely.
Absolutely.
Thank you so much.
Thank you, Lauren. Thank you, Heather. And we'll see you soon.